This is one of my worst cases. I don't have too much details, but I will show whatever is available here. This was a 40-year-old patient who came with severe right L5 radiculopathy since 1 month, and he had a significant EHL EDL weakness, very severe pain. That is what you see when a DRG is compressed. This is his MRI. You can see there is a huge fragment which is foraminal and extraforaminal at L5 S1 level. But in the sagittal section you don't see it. If you see it now retrospectively. And he has a stable lytic listhesis. It was not unstable. It is just an incidental finding. So I thought I will do it endoscopic and remove it. So I took him first for endoscopic discectomy. So, but I could not find the fragment. I decompressed the exiting route. I decompressed the traversing route. Axilla was free, but fragment is not seen. So I thought I missed fragment somewhere. So I went in again next day. Again, I went transiliac because I thought I am not able to get this fragment through the suprailiac approach because that has limitations. I went transiliac. Again, I am not able to find the fragment. Pain is same. No difference because I know that fragment has not come out. That means it is there somewhere. So repeat MRI done because you want to know where it is. Repeat MRI, absolutely same picture, no change at all, except your transiliac window and your operative track is there. Apart from that, picture is same. So this is the MRI. So then I went to MRI console and see where it is, and I targeted this fragment on the MRI. So what had happened was actually this fragment was lateral to the exiting route. So it is lying between the transverse process and the exiting route. So there is no way you can approach from a transforaminal approach. This is extremely rare. You don't see these kind of herniations. So this is how I targeted. I measured the depth from the skin and I measured the depth from the midline. So this is how place the needle. This is where our pain physicians do root blocks. So this is the exact triangle where this fragment was. You can see the targeting here, the lateral view and AP view. And this is my dilator inside in the same place, just lateral to the exiting route. And you can see the position. So this is a blind procedure in C-arm. Then we put my scope, endoscope here. You can see the cannula, just lateral to midline and lateral to the root. And I am just touching the transverse process of L5 here. And this is a picture. So at 5 o'clock is the transverse process. You can see the bone. And this is a fragment just below that. You can see this massive fragment. And so you can see the exiting route which is going down there. And you can see the transverse process very clearly and the root there. In between was the fragment. So patient had, this is the fragment which was removed, and patient has immediate relief after this fragmentectomy and he is fine now. It is about 4 or 5 years. Nothing was done for listhesis, but I operated him 3 times. This is one case where I had done endoscopy 3 times, but patient had full faith in me. I told him very openly that I have not removed the fragment. I need to go in again. And 3rd time he said, please do it. This should be the last time. So I could get away with this case without any issues. Thank you. Any questions I will answer.